And speaking about robotics, I can show you, for example, central hepatectomy enlarged segment 1. You can see on the upper right, left hemiapatectomy with reconstruction, with biliary reconstruction. And you can see in the lower part of the image, inferior vena cava thrombectomy being done by a kidney tumor. And this was the reason we, in fact, began also with liver transplantation being done by this, but because we started getting some experience in vascular resections with this type of surgeries. And also, for example, with robotic surgery for classic tumors. In fact, we published this study in Annals of Surgical Oncology with the group of Tampo, from my friend Isvato Sucandi, again, with our friends from Modena, from Fabrizio De Benedetto. And in fact, this publication has the first 38 patients submitted to hepatectomy with curative intent because of Klatskin tumor. And here you can see that we had some vascular resections because of Klatskin tumors. And in the image, you can see a type 3B patient being submitted to vascular resection. So we had experience in complex robotic surgery, including biliary and vascular reconstructions. We had extensive experience in liver transplantation, and we had experience in complex robotic surgery, including, in fact, perihilar cholangiocarcinoma, besides the reconstructions. So we thought that we could have reunited the conditions to start robotic liver transplantation, as was started in the United States months before we started our program. So we prepared. We got and acquired the material necessary, vascular clamps, laparoscopic clamps, bulldog clamps also. And you can see here that we trained with discarded grafts, discarded venous grafts, discarded arterial grafts. This was done every day after the finishing of the program of robotic surgery. We would stay here and we would use the grafts that we didn't use for transplants to train anastomosis like this. And then we selected patients. We started with 6 recipients, low MELD, preferably HCC, 1 patient with liver metastasis from the jejunal neuroendocrine tumor, small livers, not significant portal hypertension, and a BMI of less than 35. In fact, it was even less in the beginning. And we waited, and I would say we waited perhaps 3 months or more like this. And the team was ready, but started to get actually a little demoralized by this waiting because we didn't have the right recipients in the proper position in the lists, and we couldn't put the patients in the list before the other patients. So one day we had this very nice donor. This is a very nice donor for us in Portugal, 51 years old female, vascular cerebral accident, AST, ALT, GGT were normal, no steatosis, next to the hospital. And in fact, we decided to use this donor and to perform our first robotic deceased donor whole liver transplantation. So amongst all these patients, we decided to choose the first patient on the list. It was a 51 years old ethanolic and HCV cirrhosis patient with refractory ascites with a MELD of 20. And this was February 4th, 2024. And this was, in fact, the first robotic liver transplant in Europe, the second in the world. And you can see here the video of the first transplant. You can see that the patient is very sarcopenic, a lot of ascites. He had an umbilical hernia, leaking ascites. And this patient, in fact, I can tell you, that was a patient that had a previous spontaneous bacterial peritonitis, and it was in very bad condition. So you can see here the beginning of the operation. You can see the artery, and then you can see the dissection of the bile duct. You can see the portal vein. Of course, it's not a perfectly compensated patient. It's not one of those patients that doesn't bleed at all. This is segment 1 being dissected and the liver being separated from the IVC. This is the right parts of the transplant hepatectomy, mobilizing the right liver. Of course, the patient has a very high INR, very low platelet count, so it bleeds naturally. Cutting the right hepatic vein, preparing for the middle and left hepatic vein to be cut. Then we go to the portal vein. Then we go to the middle and left hepatic vein and perform total hepatectomy. Then we tested the IVC and we extracted the specimen through a midline periumbilical incision, and we introduced the new specimen. You can see here was a little tight, but no trauma at all. It was the first, and it's very impressive because the image that we saw after putting the liver in the correct position was this. It was as if the liver would fall naturally in this position. And in fact, we are clamping the IVC, starting the implantation, cavo-caval anastomosis, using Gore-Tex sutures. You can see here the cavo-caval anastomosis. Posterior face is being done. Now the anterior parts of the caval anastomosis. You can see very, very well all the structures. So the IVC is being finished. We try to do this exactly the same way as we would do in open. So last part of the IVC, we go to the portal vein. And I have to tell you, we modified so many things with all these cases that we have until now. This is the portal vein, and many, many things about the technique are modified, but in fact, this was the first. And we prepared rather well, but still, we were surprised by small intraoperative events that we had no idea that could happen, even with all the preparation. You have the portal vein, and you can see here an example of Murphy's Law. You are prepared to flush, as we would do in open. We're going to flush the portal vein, and look what happens. We had a clot right in the middle of the camera. Of course, nothing happened. It was all okay, but it was just an example of one of many things that can happen. So we finished the portal vein, the liver growth factor. Again, we modified this now, and we unclamp. Unclamp the portal vein, we unclamp the IVC. Then we proceed to the artery. You can see here there is a very good outflow. The portal vein is very nice also. So we go to the artery. At this point, we were still using the regular robotic instruments. We then changed to microvascular instruments that the robotic platform has. This is the artery. And you can really see here an advantage in terms of dissection and the reconstruction. You can see very well. You have no tremor. You have very good visualization. And in fact, even if you have, if you are a technically perfect surgeon, there are very difficult patients that can be difficult to be done. And in fact, with this platform, you can overcome this type of problems. So the artery is done. Then you have reperfusion, arterial perfusion, and you proceed to the bile duct. And again, in the bile duct, you do it exactly as in open. We are using a PDS suture that we usually use in liver transplantation. Continuous suture, it's a rather nice bile duct. And this is the ends of the operation. You can see the anterior face still of the bile duct. And then it's finished, and you can see here the aspect of the liver. So we took 9 hours. Ischemia time was 70 minutes, and you can see here there was no post-operative complications, and this patient was discharged home at day 11. I can tell you, for example, the date of discharge is a very subjective matter because it depends whether you have fast track programs or not. It depends on the social conditions of the patients. But in fact, for a patient like this to be home at day 11 in the condition that he arrived was quite good for us in our center. And so we actually published the first 3 patients in our center with the first 3 patients in Italy, again with my friend Fabrizio De Benedetto from Modena. And it's interesting to see, these are some of the incisions of the first patients. We modified all this, and I will explain what we're using now. Now we are using a lower midline incision, and we are keeping the robot docked the whole procedure, and this saves a lot of time. But you can see here, when you see the results, you can see the first 6 patients. In fact, you have a warm ischemia time in some patients of 90 minutes, some of them 70, 55.